Section 2 has a clinical focus and will cover indications and contraindications, patient selection and assessment, treatment protocols and parameters, application techniques and safety, evidence and clinical outcomes. Indications and contraindications for radial shockwave therapy. Indications. Radial shockwave therapy is primarily used for chronic, more superficial musculoskeletal conditions that have not responded to other conservative treatments. Examples include plantar fasciopathy, see NICE Clinical Knowledge Summary 2024, Achilles tendinopathy, highlighted in the NICE Clinical Knowledge Summary 2020, patella tendinopathy, rotator cuff tendinopathy, NICE Interventional Procedures Guideline IPG 742 from 2022, and tennis elbow, NICE IPG 313 from 2009. Golfer's elbow, greater trochanteric pain syndrome, NICE IPG 376 from 2011. Radial shockwave therapy can only be utilized in the absence of contraindications. Contraindications to the treatment. Some of these are absolute, some are relative, but it is vital that as clinicians we always screen for these before use. Let's start with the absolute contraindications. They are blood clotting disorders, anticoagulant medication, tumour or cancer, pregnancy, open growth plates, acute infections or inflammation, and treatment over major blood vessels or nerves. So, blood clotting disorders, for example, haemophilia, and disseminated intravascular coagulation are contraindicated due to the risk of bruising and bleeding. Use of anticoagulant medication. High-dose anticoagulants can also increase bruising and bleeding risk. We do not use the treatment over an area where there is a tumour or cancer. Pregnancy, we avoid using the treatment over or near the uterus and lower back. Open growth plates. The treatment is not for children or adolescents with incomplete bone growth. Acute infections or inflammation, local skin infections, cellulitis or wounds in the treatment area are avoided. Over major blood vessels or nerves, for example, we would not use the treatment over the carotid artery in the neck. Relative contraindications, where the treatment is possibly used with caution or an adjusted approach, include local osteoporosis, which is potentially at risk of microdamage, prosthetic implants in the targeted area, especially metal, as shockwaves can be reflected, severe peripheral neuropathy, which can reduce sensation and mask excessive force, recent corticosteroid injection, for example within the last 6 weeks. Corticosteroid injection can cause connective tissue weakening. If the patient has severe cardiovascular or neurological conditions, it is advised to seek specialist approval before commencing treatment. Radial shockwave therapy is not indicated for complete tendon or ligament tears, acute muscle ruptures, nerve entrapment syndromes such as carpal tunnel syndrome, unless you are targeting the related myofascial pain, or bone fractures, except some non-unions which need focused shockwave therapy. In summary, radial shockwave is generally safe when used properly and for the right condition, but it is vital to screen for the contraindications outlined in this section. Patient selection and assessment, clinical reasoning. Patient selection and clinical reasoning are key for safe and effective use of radial shockwave therapy. The evidence shows that outcomes depend not just on applying the device, but on choosing the right patient with the right diagnosis at the right stage. To help achieve this, the following clinical reasoning framework for radial shockwave therapy may be useful. Step 1, confirm the diagnosis. Step 2, evaluate suitability of the presenting condition. Step 3, screen for contraindications. Step 4, patient-centered considerations. And Step 5, set treatment goals. Looking at each of those steps in more detail. Step 1, confirm the diagnosis. Radial shockwave therapy works best for chronic musculoskeletal conditions that have failed conservative management. Assess with history to understand the onset, the chronicity, aggravating and relieving factors, and any failed prior therapies. Physical examination, explore for local tenderness, reduced function, and typical loading pain. Imaging. Ultrasound scans, MRI scans, or X-ray can be used as needed to confirm tendinopathy or calcification and to rule out complete tears or tumours. Remember, if pain is due to an acute tear, systemic disease, or nerve compression, radial shockwave therapy is not indicated. Step 2. Evaluate the suitability of the presenting condition. Ask, does the patient's presenting condition fit the typical successful profile? Good candidates: chronic superficial tendinopathy or soft tissue lesions, for example, plantar fasciopathy, tennis elbow, Achilles and patella tendinopathy. Also greater trochanteric pain syndrome, all of which has been unresponsive to other treatments. Poor candidates: acute injuries, fractures, complete tendon tears, generalized arthritis pain without local tendinopathy, and pain of unclear origin. Step 3. Screen for contraindications. Absolute contraindications are tumour, pregnancy at the target treatment area, infection, open growth plates, severe coagulopathy, and treatment over major blood vessels and nerves. Relative contraindications are recent corticosteroid injection, severe osteoporosis, and implants in the treatment area. Step 4. Patient-centered considerations. Consider the patient's pain tolerance, as radial shockwave therapy can be uncomfortable and the patient needs to be able to tolerate percussive sensation. Expectations. Clarify that results are gradual, often peaking 4 to 12 weeks after treatment, and treatment success is not guaranteed. Compliance. Best results come when combined with rehabilitation exercises such as eccentric loading programs and heavy slow resistance or stretching regimes. Psychosocial factors. Consider the patient's motivation, activity demands, and occupational goals. These should all be aligned with the treatment. Step 5. Set treatment goals. Examples include pain reduction, functional improvement, improved range of motion and strength, and a return to work and leisure activities. Here are some very basic clinical reasoning examples. A patient with persistent plantar fasciopathy who has not improved with orthotics and exercises. In this scenario, radial shockwave therapy is indicated based on a strong evidence base and NICE guidelines. The persistence of the symptoms, clear local pathology, lack of improvement with other treatment modalities makes radial shockwave therapy safe to apply. However, in a patient with acute Achilles tendon rupture, radial shockwave therapy is contraindicated and the patient requires urgent surgical input or immobilization. Shockwave therapy is not indicated for acute or large tendon tears or rupture. Another basic example would be a patient with chronic calcific rotator cuff tendinopathy with night pain who had minimal benefit from a corticosteroid injection. Shockwave therapy would be indicated, but the evidence would support focused over radial for this if the lesion is deep-seated. From a reasoning perspective, there is good evidence of successful outcomes using shockwave therapy for this condition, especially for calcium resorption. And another indication is that the patient has persistent symptoms despite undergoing other treatments. Another component of clinical reasoning required in this scenario is ensuring that at least 4 to 6 weeks have elapsed since the patient had their corticosteroid injection before shockwave therapy treatment commences. Some key takeaways and reminders at this stage. Radial shockwave therapy is best reserved for chronic, localized tendon or fascia conditions where conservative care has not helped. Careful diagnostic confirmation, contraindication screening, and patient expectation management are essential. It should be seen as a stimulus to promote healing, not a standalone cure. Rehabilitation and loading programs must accompany shockwave treatment. Thank you for your attention. If you are considering adding shockwave therapy to your clinic, please get in touch with the team at Eureka, who will be happy to discuss device options and implementation strategies.